Again, this session is going to be about emerging hot spots in diabetes, and we have two chairpersons for this session. May I invite Dr. A. Shivakumar and Dr. D. Damodaran to the dais.
Good evening to all. Congratulations to the organizers and thanks for the opportunity given. We are already running short of time by half an hour. I eagerly waiting to hear about double diabetes by Charles Bronson. Charles is a young and energetic diabetologist. Currently he is working as assistant professor of diabetology in Stanley. Over to Charles.
Respected chairpersons, respected co-speakers, respected audience, respected members of the organizing committee, thank you for kindly giving me this opportunity to speak on this topic of double diabetes. And as we know, type 2 diabetes is a major public health problem throughout the world, and it's attributed to insulin resistance and gradually progressing beta cell failure. Type 2 diabetes, it's quite a common disease and is associated with high heterogeneity. While type 1 diabetes is largely an autoimmune disease characterized by near absolute insulin deficiency. If the type 1 diabetes patient, to put in simpler terms, if the type 1 diabetes patient in course of time gains weight and develops features of insulin resistance, then this condition becomes a distinct entity, a phenotype, which is a mixture of type 1 and type 2 diabetes. It's called double diabetes. What is the importance of double diabetes is that individuals with double diabetes have an increased risk of developing complications over and above the risk conferred by having type 1 diabetes and also the degree of glycemic control. So this is probably the first or the earliest description of type 1 double diabetes by two people, Bernard Toype and Christian Burgess, in the Lancet in 1991. What they did was that they analyzed people with the type 1 diabetes and saw who got a family history of type 2 diabetes. So when they analyzed those people, they saw that about a quarter, that is 25% of type 1 diabetes had a family history of type 2 diabetes. Those who had a family history of type 2 diabetes had high insulin requirements, and they had used to gain a lot of weight, and they had high insulin requirements. So they put forward a new term called double diabetes. Then they also prefer to call it as type 1C diabetes. After type 1A and type 1B, they prefer to call it as type 1C diabetes or double diabetes. So mechanisms of acquiring double diabetes. What are all the factors how a person can acquire double diabetes? First is a family history of having type 2 diabetes, having excessive weight gain and features of metabolic syndrome, and also the features of insulin resistance. So coming to the family history of type 2 diabetes, if an individual with type 1 DM who has a concomitant family history of type 2 diabetes is likely to harbor a genetic predisposition to develop insulin resistance and a type 2 diabetes phenotype along with his type 1 diabetes. This insulin resistance due to family history may either develop later in the course of disease or may even present during the diagnosis of type 1 DM, or sometimes it may even contribute to the earlier presentation of type 1 diabetes. So data from the Finnish diabetic nephropathy study, which involved more than 1,800 people, and the DCCT trial showed that those type 1 diabetes patients who had a family history of type 2 diabetes had higher BMI and a central weight gain, higher HbA1c and triglycerides, higher insulin requirements, and also elevated LDL and apolipoprotein B levels. And coming to the second point, that is an excessive weight gain or obesity and metabolic syndrome. Insulin, as we know, is an anabolic hormone. Intensive insulin therapy leads to, as in type 1 DM, leads to for optimizing the glycemic status, might lead to weight gain and further increase the risk of developing double diabetes in those who are genetically susceptible. The DCCT trial and its subsequent analysis showed that if they divided those people who gained weight into 4 quartiles, and those who had the highest weight gain, that is the excessive gainers in the 4th quartile range of weight gain, had a high insulin dose, high BP, and high non-HDL cholesterol. Furthermore, those individuals whose BMI increased by greater than 4.3 kg per meter squared in the DCCT study period had greater intima media thickness and displayed a trend towards greater coronary artery calcium scores, providing evidence for macrovascular pathology in this weight gaining group. In addition, excessive weight gainers displayed a tendency towards higher number of cardiovascular events after a follow-up of about 26 years in the DCCT analysis. And in a study called the EuroDiab study, where more than 3,000 people, type 1 DM people were analyzed from 16 countries across Europe, components of the metabolic syndrome, that is central obesity, hypertension, etc., in type 2 diabetes mellitus patients were found to be associated with an increased cardiovascular mortality. And features of insulin resistance, how it contributes to double diabetes. Insulin resistance per se is found to be associated with asymptomatic atherosclerosis and cardiovascular disease in people even without diabetes. That is, insulin resistance per se is an independent risk factor for cardiovascular disease. The gold standard for measurement of insulin resistance is the euglycemic hyperinsulinemic clamp technique. However, it is very cumbersome and it's suitable mainly for studies. So we need an alternative for use in clinical settings. There came a formula called the estimated glucose disposal rate. It is a simpler method, an alternative method. So this is the equation, the EGDR equation. This EGDR equation can be calculated either using the waist circumference, that is the WC EGDR, or the waist tip ratio. This is the waist circumference formula. Here we have three variables: waist circumference, hypertension, HbA1c. Waist circumference is measured in centimeters, HbA1c in percentage, and hypertension is not measured, but it's categorized as either a plus or a minus, that is present or absent. If the estimated glucose disposal rate is less, which means that the person has got a higher insulin resistance. So EGDR is obviously a continuous variable. So a decrease in EGDR is associated with an increased risk of nephropathy, peripheral vascular disease, coronary artery disease, and even death, with the lower values of EGDR conferring the greater risk. So Nystrom et al. Tried to categorize this EGDR groups into 4 groups based on cutoffs, like less than 4, 4 to 5.99, 6 to 7.99, and greater than 8. They thought of achieving that to reach a numerical value or a cutoff value to say above which level the complications tend to occur. So an EGDR of less than 8 was associated with an increased cardiovascular risk in a follow-up of 7 years. So this is the Nystrom et al. Study. Here we see on the left side EGDR is less than 4, and there the cardiovascular mortality and all-cause mortality is high. And when it's towards the value of 8, it becomes low. Coming to the prevalence of double diabetes, the prevalence of double diabetes varies based on the criterion used. In some studies where obesity was the criteria, that is BMI of 30, more than 30, 30% of type 1 DM had double diabetes. If metabolic syndrome was used as a criteria, 30 to 45% had double diabetes. And if EGDR was used as a criteria, less than 8 was used as a criteria, about 51% of type 1 diabetes patients had double diabetes. So this is a temporal trend of how the incidence of overweight and obesity in type 2 diabetes progressed over the course of time. On the left side, we have those time in the 1986 to 90s, and here the latest values. Here we see that BMI of more than 30, those type 1 diabetes who have got a BMI of more than 30, they are increasing gradually in number. And the main thing is diabetes and its complications. The EDIC study, which is the EDIC study, which is the follow-up of the DCCT, showed that HbA1c reduction decreased microvascular complications. However, this reduction in microvascular complications in the EDIC follow-up was not homogeneous. There was a heterogeneity in the rate of complications, indicating that other factors apart from HbA1c might have got a role in those complications. So Merger et al., they did a subgroup analysis of this EDIC population, and they showed that 20% of even well-controlled type 1 diabetics, those who have got, that is in the intensive phase, those who got less than 7% of HbA1c, though even among those who have got less than 7% well-controlled type 1 diabetes, 20% of them had double diabetes. Overall, whether double diabetes is present or not, those people who have got intensive control of less than 7%, they had a reduced risk of micro and macrovascular complications than those with a poorly controlled diabetes. However, they could see in a subgroup analysis that even within this subgroup of good glycemic control, those with double diabetes had a 3.5 times higher rate of complications for even identical HbA1c values, which means that this double diabetes confers a risk over and above the traditional glycemic control. And this is a graphical representation of what I said now. Overall, double diabetes increased a higher risk compared to type 1 diabetes and those even with a good control. And this is a chart or a picture which shows how double diabetes might increase the risk of complications. Here in the center point, we have insulin resistance. Insulin resistance on the left side, it affects the visceral adipocytes and leads to a subclinical chronic inflammation, which further worsens the insulin resistance. So this is a loop or a cycle, and this worsening insulin resistance leads to hyperglycemia, hypertension, and the decreased glucose uptake in the skeletal muscle, etc., and also leads to oxidized LDL, formation of atherogenic LDL. Finally, it leads to endothelial dysfunction and increased risk of macrovascular and microvascular complications. So coming to the conclusions regarding double diabetes and future directions. Having said all this, we see that the evidence of double diabetes is increasing with increased research. However, the treatment remains the same as for any other type 1 DM. There are no clear consensus to say that we can add any other drug apart from insulin in those people with type 1 diabetes mellitus. And also the diagnostic criteria are not yet clear, and international or national guidelines are not fully framed yet. And to form a diagnostic criteria, EGDR may be adapted as a credible measure for double diabetes because it is easy to use clinically and it can be used both for the diagnosis as well as for the prognosis. If we treat double diabetes and the EGDR keeps on increasing, it means that it has got a good prognosis, that the resistance is increasing. Much like HbA1c, it can be used as a diagnostic as well as a prognostic marker because it offers the measurable numerical value. So finally, wider consensus and guidelines for the management of double diabetes are the need of the hour. Thank you.
Congrats, Charles, for your excellent presentation. It's new information to EGDR. See, in MMC, we used to practice, we used to add minimal dose of metformin even type 1 diabetes. For the past 30 years, anticipating some amount of insulin resistance, we used to add metformin off-beat in all type 1 diabetes. Thank you, Charles. The next topic is new onset diabetes after transplant by Dr. V. Palnikumaran. He is a popular diabetologist in Madurai, currently working as an assistant professor in Madurai Medical College. Over to Palnikumaran.
A very good evening, everyone. At the outset, I sincerely thank the organizing committee and Dr. Shanmugam for giving me this opportunity, and thank the chairpersons for giving me the introduction. So, for a few minutes, I am going to talk about NODAT. So this NODAT is actually nothing but new onset diabetes after transplantation. It is mainly due to some pathophysiological consequences which occurs after transplantation on glucose metabolism. So with the increased modality of transplantation is being increased nowadays, this NODAT is being increased, the prevalence of NODAT is nowadays being increased, and we should know something basics about NODAT. And certain terminologies we should know. And previously, initially this NODAT was framed as post-transplant diabetes mellitus. So the difference between PTDM and NODAT is, so post-transplant diabetes mellitus is actually, it describes the presence of diabetes after transplantation, irrespective of the timing of the diagnosis, whether it was present or undetected before transplantation. Maybe undetected diabetes even before the transplant period, if it is going to be there, it is carry away even post-transplant, then that terminology is PTDM we should frame. Whereas new onset, NODAT is, it excludes, so it does not include the patients who may have had diabetes before transplantation. So without any pre-diabetes being there in the pre-transplant period, so it is named as NODAT. So subtle difference is there, but nowadays, with once again with the newer references and organizations are very much nowadays are referring PTDM as a correct terminology than NODAT. Even this RSSDA, what we are framing is PTDM, that is post-transplant diabetes mellitus. And one thing is this PTDM, that is post-transplant diabetes mellitus, does not include the hyperglycemia that occurs transiently in the immediate post-transplant period. So PTDM does not include, and the diagnosis should not be made in patients within 6 weeks after transplantation. So PTDM typically occurs after 6 weeks of post-transplantation. And coming to the epidemiology, it's more common among certain races, especially blacks and Hispanics, and very less with Caucasians. It's mainly due to genetic diversity and inconsistency in the immunosuppressive agents which are being used in the post-transplant period. And coming to the incidence, as the duration of post-transplant period increases, the incidence actually increases up to certain years, maybe 1 or 2 years. After that, it will be just plateau as that of other diabetes, similar to that of type 2 DM. So the incidence is roughly about 9.1% at 9 months, 16% at 12 months, and 24% at 36 months. And regarding the various solid organ transplants, kidney transplantation, it is roughly about 4 to 25%, and liver transplant, it will be 2.5 to 25%. And heart transplanted, which has the maximum incidence of roughly about 4 to 40%. And in lung transplants, the incidence is about 30 to 35%. So certain risk factors have been linked to the development of these post-transplant diabetes mellitus. So apart from traditional risk factors, we do have some specific and unique risk factors for PTDM development. And these risk factors can be classified as modifiable and non-modifiable. So the modifiable risk factors which comes to the platform is the immunosuppressive agents, which we commonly use in the post-transplant period, mainly the steroids, calcineurin inhibitors and mTOR inhibitors. These are the few group of drugs which may increase the risk of development of PTDM. And obesity as being an increase in the insulin resistance, and obesity being common in the post-transplant period because of increased well-being and increased intake of food, and because of the usage of steroids, obesity is quite common in the post-transplant period, also poses high risk for development of PTDM. And metabolic syndrome also definitely will do. And the risk of HCV, hepatitis C virus infection, so it directly, it has a cytopathic effect on the beta cells. It decreases the insulin secretion. By that way, it can pose the development of post-transplant diabetes. And CMV, that is cytomegalovirus infection, also induce beta cell apoptosis, and also it decreases the insulin secretion. That also poses the risk of PTDM. And hypermagnesemia, which is also one of the side effect of calcineurin inhibitor therapy, as it causes the magnesium to be lost in the urine, and also as a complication of hyperglycemia. This hypomagnesemia per se can also pose the risk of development of diabetes. And certain non-modifiable factors such as increase in age, certainly genetic races and Hispanic ethnicity, and previous history of GDM or family history of type 2 DM, and increased HLA mismatching, male sex, all these has an increased risk of development of PTDM. And acute rejection history, if it is going to be there in any during that immediate post-transplant time, that poses because of the higher usage of steroids during that period, may also pose increased risk factor. And certain end organ cause, reason for transplantation, especially PCKD, polycystic kidney disease, cystic fibrosis for lung transplant, HCV-related liver disorders, all these poses the development of PTDM to develop. And then definitely genetic factors also influence the development of risk factor for development of PTDM. So here the pathophysiology is similar to that of type 2 DM. Mainly the beta cell dysfunction and insulin resistance both play. But the main difference between type 2 DM and PTDM is the beta cell dysfunction, which is the primary modality of pathogenesis in post-transplant diabetes, added on to insulin resistance, and other than that, immunosuppressive medications. These are the three main pathogenic factors which play a role in the development of post-transplant diabetes mellitus. So these risk factors with age, viral infection, metabolic syndrome, genetics, and immunosuppressive agents will lead on to cytotoxicity of the beta cells, inflammation, autoimmunity. All will pose the healthy beta cell into destructed beta cells. This further causes decrease in insulin secretion, and further weight gain, increased free fatty acid, all will pose in the adipose tissue, liver and muscle will pose increased insulin resistance. So all these will produce the development of NODAT. So coming to the immunosuppressive agents specifically, the steroids, glucocorticoids being is one of the common drugs which are being used in the post-transplant period. It increases the insulin resistance, it reduces the insulin production, also increase the hepatic glucose production, and also it causes weight gain. By that way, it can increase the risk of development of PTDM, and it has poor appetite control, so patient used to take increased food. And so the recommendation is we have to limit a gradual reduction of prednisolone dosage from 10 mg to 5 mg, lower doses as low as possible, as that of 5 mg per day has resulted in improved insulin sensitivity, and the risk of NODAT is being reduced. These calcineurin inhibitors, especially tacrolimus and these two drugs interfere with the calcineurin phosphatase activity by inhibiting the insulin production by beta cells. So the main pathogenesis is the decreasing in insulin secretion, and the degree of hyperglycemia depends on dosage and specific medication used. And tacrolimus is more diabetogenic than cyclosporine, and this tacrolimus because it has a protein which is being highly concentrated in the pancreas, and it also expresses the SGLT2 receptors, so that it causes renal reabsorption of the glucose. By that way, tacrolimus is more diabetogenic than cyclosporine. So if you want to prefer CNI, that is calcineurin inhibitors, it's better to go for cyclosporine than tacrolimus. And come to mTOR inhibitors, so this is sirolimus and everolimus. They also diminish the insulin signaling by suppressing the phosphorylation, and sirolimus definitely poses the risk of development of NODAT, even whether it is combined with mycophenolate mofetate. And these two drugs, MMF and azothioprine, they have not been linked to the elevated risk of NODAT. So how are we going to diagnose this NODAT? So as a routine, we can diagnose with the diagnostic criteria which has been advocated by ADA, but the difference is HbA1c is not recommended in the first 3 months of post-transplant because of post-transplant anemia or because of the erythropoietin stimulating agents, and all these will cause some confounding factors and may cause falsely low HbA1c. So it's better to go for OGTT, which is the gold standard diagnostic modality of diagnosing NODAT. And how are you going to screen the for NODAT? So ideally in the post-transplant period, every week for first month we have to go for fasting glucose or OGTT, or after that you have to screen screen for NODAT from 3rd month, 6th month and 9th month, and from there every annually you have to screen for NODAT for the post-transplant patients. So coming to the management, so the immediate post-transplantation period is the patient will be somewhat sick, and especially if it's less than 1 week, they should be managed as that of critically ill or non-critically ill. The ideal choice of treatment will be insulin. For any hyperglycemia more than 180 should be treated with intravenous insulin infusion therapy, whereas in non-critically ill patients we have to go for subcutaneous insulin therapy. So no role for any OAD at this time. And in early post-transplantation period, that is 1 to 6 weeks, you can go with whenever there is a persistent hyperglycemia, you can advise SMBG. So and better you go by insulinization. NPH insulin once a day in the morning, it matches with the afternoon glucose peak observed with the glucocorticoid induced hyperglycemia. So it's so if the patient is taking morning steroid of prednisolone 5 mg or 10 mg, you can administer NPH in the morning. That will cover the glucose peak produced by the prednisolone. With mild hyperglycemia and low insulin requirement, OAD can be advocated in this group of early post-transplantation period. And for more than 6 weeks, that is the proper management of post-transplant diabetes mellitus, you have to follow MNT and pharmacotherapy with OAD and insulin therapy. So MNT, that is medical nutrition therapy, should be done for as the other type 2 DM or type 1 DM. So ideally dietary modification should be done, weight reduction should be advocated, and physical exercise to lose the weight should be advocated. And coming to the pharmacotherapy, so all pharmacological drugs are advocated. Metformin can be used whenever the eGFR is more than 45, and between 30 to 45 you can reduce the dose of metformin, and less than 30 it is not advocated. In sulfonylurea you can go by glipizide or glimepiride. Meglitinates are good choice, especially ripoclinide. And coming to DPP-4 inhibitor, except linagliptin, all other DPP-4 inhibitors need dose reduction. And sitagliptin, it may prolong QT interval whenever the patient is on cyclosporine. And GLP-1 receptor agonists and SGLT receptors also, inhibitors are also being used. So coming to a few point of SGLT inhibitors, so they are very much useful for whenever the patient is on tacrolimus. Tacrolimus induced NODAT, actually it causes the SGLT2 SGLT2 receptor in the urinary tract. So especially empagliflozin, by being acting on these SGLT2 inhibitors, as a SGLT inhibitor, it will reduce the SGLT2 receptors. By that way it can reduce the NODAT occurrence. And insulin therapy is advocated whenever the patient is having HbA1c of above 7 with poorly controlled with the OAD. And insulin therapy you can go by either subcutaneous or subcutaneous, either other regimes, either be it twice daily or basal bolus regimes can be advocated. So in nutshell, this is the time frame and what's the management we have to give for NODAT. And so immunosuppressive agents adjustment is also very much important in the management of NODAT. So glucocorticoid therapy, as already told, you have to maintain the you have to reduce the dose of steroids and maintain it lower dose. Complete withdrawal is not recommended. And CNI, that is tacrolimus, is being more diabetogenic. You can prefer cyclosporine. And coming to the diabetogenic effects, so MMF and azothioprine can be preferred over cyclosporine and tacrolimus. And certain novel approaches are also being there. Imiglamine, because it's being targeting the compromised mitochondrial function, may do some help, but a lot of studies has to come and has to inform. And coming to the complications of NODAT, NODAT definitely correlates with neuroretinal degeneration, and also it causes the development of nephropathy and neuropathy as that of type 2 DM. And long-term consequences, definitely NODAT significantly impacts patient survival, graft rejection, graft loss, and also infectious complications, and also they pose a great impact on the cardiovascular disease. So there is a strong correlation between NODAT and the CV diseases, and these are all the mechanisms. Apart from hyperglycemia, hypertension, dyslipidemia, and inflammation, all these pose to the development of CAD, increased CAD risk and cardiac failure. So prevention is more important. So you have to screen for any patient planned for transplant. You have to screen them, and you have to early post-transplant intervention in the form of screening and advocating a good diabetic control should be advocated to prevent these NODAT related complications and death. Thank you so much. Thank you for patient hearing.
Thank you, sir, for your detailed presentation. It's a new topic, a rising topic, very detailedly explained. Thank you, sir. The next topic is a very interesting topic, potentials of pre and probiotics in diabetes. Already we know that gut microbiota is very important for all organ system. The gut controls your liver, gut controls your brain, gut controls the heart, kidney, endocrine system, immune system. So we have got multiple axes, gut with multiple system. And here we are going to see the role of pre and probiotics in diabetes by Dr. N. Vetrivel. Over to you, sir.
Good evening, one and all, respected chairperson and my friends. This important topic, which is mostly neglected in the medical arena and undermined too. But this is a very, very evolving subject in the medical sciences in recent times. I present and submit to this doyen, who is my mentor in diabetic knowledge. See, it appears that gut microbiota are deeply interrelated with the diabetes. Recent studies, human microbiome are capturing attention of us worldwide by focusing on the interplay of gut microbiota and diabetes. We paint a clear picture how strongly microbiome are interrelated, associated both positively and negatively with this condition. There is a clear and growing evidence, a close relation between the microbiota and diabetes, and this is a worthy of future investment and research efforts. Way back in 2.5 million back, Hippocrates, all diseases starts from gut, health is determined by microbiota in the gut, death sits in the bowels, and a bad digestion, root of evil. Let food be thy medicine, and medicine be thy food. And after this long period, now only we are coming to appreciate the propriety of the statement. The gastrointestinal tract is a complex, distinct population of microbiota that compress this, acclaimed the taxonomy. We know that diet can change the gut microbiota and may influence the metabolism too. Amazingly, we carry 2 kgs of this microbiota, which is allobuoyant. People are sampling their own pieces and taking a lot of probiotics in the form of yogurt, kombucha, kefir, and try to foster good bacteria. The science is exploding like anything. Just in early stages, we are making the sense of it now. Man is allobuoyant, and the microbiota outnumber the human genome. There are a lot of trillions of cells are there. The normal flora is a delicate balance of beneficial and harmful bacteria. And the imbalance is going to be there to produce variety of disorders. Gut microbiota consists of only 4 phyla, namely the Firmicutes, Actinobacter, Bacteroidetes, and Proteobacter. Each and every one has got their own functions in it. So when you see, they produce short chain fatty acids by the the saccharolytic fermentation of non-digestible food products, and they inhibit the production of LPS, lipopolysaccharide, and they convert the bile acid to secondary bile acids, which are beneficial, and they are doing immunomodulation, and they protect the gut integrity by production of mucin. So there are a lot of functions, but these bacteria are manipulated by our blunderbuss modern diet and pharmaceuticals in the name of antibiotics and PP4 inhibitors, and geographical location also, lifestyle changes, sedentarism and other things, and infant feeding and the mode of delivery also affect the taxonomy of phyla in the younger age group. and stress in the form of metabolic stress, psychological stress, and the sedentarism, all will produce a disbalance in the microbial population. So finally, whether it is external influence or internal influence, when you have itching on the diversity of the microbiota or the robustness of the microbiota, what we produce is a dysbiosis. Dysbiosis will produce disease, whereas eubiosis will produce health. So lot of ranging from CNS, array of diseases, CNS, pulmonary, hepatic, and heart diseases. You know, cardiometabolic health is very important. Good bacteria inside the gut maintains cardiometabolic health, including the weight and the free from diabetes and free from mitochondrial dysfunction and cancer. So we have to see the importance of this Firmicutes and bacteroides. See, when in weight gain, because the bacteria is the important one which produces the energy harvestation and accumulation, so that they play a vital role in maintenance of weight also. For example, if you see, when a person is lean, his bacteroides is higher when compared to Firmicutes. When he is obese, the Firmicutes is more and bacteroides is there. So there is an imbalance in the gut microbiota, producing in the disturbance in the weight gain. So several studies have reported that gut microbiota dysbiosis is a factor in rapid progression of insulin resistance. The gut microbiome dysbiosis may reshape intestinal barrier function and host metabolic and signaling pathways, which are directly indirectly related to the insulin resistance in type 2 DM. Thousands of metabolites derived from this microbiota play a havoc in production of diseases. Any change in the gut microbiota can shift the host metabolism towards increased energy harvest and during diabetes and obesity. Published literature are reviewed for better understanding of this dynamics of gut microbiota. Factors that potentially induce gut microbiome dysbiosis and their relation to the progression of disease are studied. See, the dysbiosis, what is the pathological event? See, when the short-chain fatty acids like butyrates, propionic acid, acetate are not there, they will produce lot of havoc. Example, the short-chain fatty acid, butyrate, propionate, acetate will be helpful for kindling the GPR41, GPR43, which were formerly known as pre-fatty acid receptors 1, pre-fatty acid receptor 2. But they will be, this pre-fatty acid receptors will act as a enteroendocrine sector to produce more amount of GLP-1 and pancreatic polypeptide double Y, and they produce lot of benefits in the pancreatic side. They improve the insulin secretion, they improve the suppression of glucagon, and they mitigate the beta cell apoptosis. They enhance the proliferation of beta cell. Thereby, your insulin sensitivity is increased. But on the other side, the good bacteria prevents the emanation of LPS, lipopolysaccharide, from the wall of the pathogenic bacteria. This LPS, lipopolysaccharide, when it enters into the gut, creating the havoc in the occludin, suboccludin pathway, there will be exudation of these bacterial metabolites, creating what we call it as metabolic endotoxemia, disrupting the endocannabinoid system. So there is a inordinate exuberant of the pro-inflammatory cytokines, which is precursor for insulin resistance. But good bacteria, by the conversion of primary bile acid to secondary bile acid, lithocholic acid or deoxycholic acid, confers positive effects over the insulin secretion by stimulating GLP-1 and other things and mitigating the emanation of the pro-inflammatory cytokines and chemokines. The same. So, lipopolysaccharide is the pro-inflammatory producing metabolic endotoxemia, whereas dietary fibers upon saccharolytic fermentation produces short-chain fatty acids, which are creating the beneficial effects which I have alluded to. The primary bile acid converted into secondary bile acid, lithocolic and deoxycholic, which is important for improving the insulin sensitivity and decreasing the insulin resistance. Same. So there are the metabolites which are good for in the presence of good bacteria like Lactobacillus acidophilus, Akkermansia, Mucinophilia, and Bifidobacterium longum, and Saccharomyces boulardii. All these are important. This thing, you know, all we know. Sorry to say, I am not selling the brand VSL3, which is mentioned in all literature when we previewed the journals. VSL3 has 8 important species, which is helpful for us to mitigate certain amount of metabolic disorders. So dysbiosis is very bad because it is decreasing the insulin sensitivity and increasing the insulin resistance and increasing the gut permeability, producing metabolic endotoxemia and bacterial translocation, and there is a heavy LPS. This is a very, you can see, decrease in GLP-1 secretion, increase in tumor necrosis factor alpha and interleukin 10, and there is an increase in interleukin 16 and HbA1c increase, and there is a decrease in short chain fatty acid release. So the converse opposite when there is a homeostasis, euboesis. The same, the diversity of good bacteria in the gut will produce lot of good things, but the dysbiosis, evidenced by animal models and human experiments, will produce all sorts of complications. So there is a clear role of gut microbiota and its metabolites in the creation of complications ranging from neuropathy up to the diabetic nephropathy. So in order to resume the normal functions of the body, it is essential to reproduce the normal flora. How you will do? You will do by giving probiotics and prebiotics. What is probiotic? Probiotic is the living organism we infuse into the oral gut by to increase the gut diversity and gut robustness. Prebiotic is a material, chemical substances. It's a food to the probiotic or put to the gut microbiota. When prebiotic and probiotic join together, we call it as symbiotics. Postbiotic is the metabolite product of gut microbiota and the metabolite product of probiotic or prebiotic. So to add the terminology, when it is derived, a pharmaceutical usage, we call it as pharmacobiotics. When it is, there is a nutritional benefit, we call it as nutrobiotics. So this is very good. Whether probiotic or prebiotic, they, because of the mechanism I alluded, like GLP increase and the short chain fatty acid, increasing the GLP secretion, polypeptide WY, and increasing the GIP, they will produce increased insulin secretion and they mitigate the secretion of glucagon also. Finally, there is a euglycemia. The same, each and every, whether it is symbiotic, probiotic or prebiotic, they have got an important function of maintaining the milieu interior of Glad-Bernard in the, the homeostasis, the glucostasis is concerned. So gut microbiota, whether it is prebiotic or probiotic, because of the increase in secretion and short chain acid secretion, bile acid conversion into secondary bile acid, and adipose tissue regulation because of the the permicutous and bacteroides ratio, they maintain improved glycemic control. Lot of things have come. The prebiotics have got the inulin and the organism, the food to the organism, plus oligofructosaccharides. All this will combine together. There are a lot of experiments. You know, to our dismay, there are 5,400 papers, which we are not aware, produced even from the 1994 up to date. So the 5,400 papers clearly reveal the association of gut microbiota effectiveness in the diabetic sector. So here comes vegan and animal food. See, if you have plant food, which is fiber rich, you have bacteroiditis and Prevotella, Akkermansia, Mucinophilia, and Bifidobacterium longum. They will create all sort of good things. Increase in short chain fatty acid secretion and anabolic enzymes, butyrate and propionate acetate secretion, and riboflavin and glutamate synthesis, immune homeostasis, and to the gut mobility is increased, insulin sensitivity increase, and there is no leaky gut syndrome. Converse is the opposite when you take the non-vegetarian food. Professor Sam J.P. Moses used to tell, one has to be vegetarian like fruitarian and nutarians. So this is suitable for this. So when you take vegetarian diet, you will produce lot of good things in the gut. These are the organisms. So get a variety of probiotic and prebiotic in our setup. See, the whole wheat products, old rice, this porridge, rice porridge, and potato, nuts and seeds, one side, another side, pulses, legumes, oats, skins of fruits and vegetables, they act as prebiotic for the probiotic. So you have prebiotic in onion, garlic, beets, Brussels sprouts, artichoke. So imagine when you see prebiotics in day-to-day use, onion, garlic, asparagus, bananas, leek, bread, artichoke, all are useful. See, every skin of the fruits or vegetables is a non-digestible fiber which are fermented by the saccharolytic species of this organism. Probiotics, you can imagine old cheese, kefir, the miso soup, sour cream, pickles, probiotic milk, and yogurt. All these are available in our setup, in our center. We are studying, we are going to produce, we are the final stage, yogurt and the pitta of dragon fruit, yellow, white or red, is going to be giving lot of good things. They are reducing fasting, postprandial, HbA1 reduction. They are improving the parameters in the lipid sector, and they are improving the high sensitivity C-reactive protein. So not only glycemia is controlled, but also the pro-inflammatory also is controlled because of the mechanism I alluded to in the earlier talk. So these are the things which only 1 minute I took. So when you take probiotic and prebiotic, there is a decrease in gluconeogenesis. There is a decrease in inflammatory cytokines. Pathogenic microbiome decreased so that LPS sector is out. Increased regulatory and T cells, immunomodulation. Increased production of bactericin, killing the pathogenic bacteria. Increased production of short chain fatty acids, antioxidant, and satiety, all will help for a normal restoration of eubiosis and a healthy life. Even in probiotics are useful in GDM. So food that good for your microbiome include unprocessed food, fiber-rich food, eat all the fruit, whole fruit and vegetables, and yogurt. So these are the benefits which I have alluded to. I do not want to repeat. So finally, to conclude, microbiota metabolites have strong influence in diabetes mellitus, though the various relationship with host metabolism implication in several pathways. There is a bidirectional relation between diabetes and gut microbiome. Diabetes changes the composition of the microbiota. That composition change will affect it still, it's a vicious circle, affect the diabetic status. So evidence by coming usage of probiotic and prebiotic, and the latest, which is robustly talked, fecal microbial transfer, will clearly glean the importance of microbiota in amelioration of this metabolic disorders like obesity and diabetes, even in hypertension and cardiometabolic sector. So further clinical studies, meta-analysis, thanks to the Human Microbiome Project funded by European Society of this thing, and the MetaEat program funded by the National Institute of Health, and Korean Aviatome project, which are offering, which are identifying the bacteria which is not there in the gut, replenishing them in the form of this thing. So what is today as a functional food should become a therapeutic arsenal for us to use to mitigate all this testing. Thank you very much.
Thank you, sir, for your excellent presentation. Questions at the end of the session. Now I invite Dr. Ranjit Pradap to talk on social media and diabetes. He is a popular diabetologist in Thambaram. He is currently working as assistant professor of diabetology in MMC. Over to Ranjit.
Thank you, sir, for the nice introduction. Ladies and gentlemen, a very good evening, one and all. Today's my topic is about diabetes in social media. Before moving to my topic, I would like to thank the organizing team, the scientific team, for giving this me wonderful opportunity to present my topic in front of the august audience. The new dawn, the new age in social media. We all know these are the various social media apps we are currently using. Not even a single day, we are not missing this app by using. And we are celebrating Amazon Great Indian Festival as well as Flipkart Big Billion Days. There is an important for this. Whenever you are going to use a social media, specifically in diabetes or by the healthcare professional, we are going to do a lot of things. After the invention of that smartphones and development of digital technology, it has made very useful for the management of diabetes for the patients. Generally, social media is mainly to communicate and to form or to generate social networks. It is an internet-based communication platform that facilitates interactive, community-based content creation and sharing. The reach is very huge. There are estimated that more than 3.5 million people uses internet, out of which 88% of adults spend more than 3 hours of screen time. But keep it in the mind, when you are going to use the screen time of more than 2 hours, then you are addicted to the social media. Not only that, even in the underdeveloped countries, there is a vast increase in usage of internet from 17.6% to 35%. What about the impact of social media in the education? Actually, it improves the engagement by approximately 83%. Not only that, it also has a positively affect health behaviors and outcomes by 89%. What about the social media in India? Whenever you're going to ask a diabetic patient, they will be telling the doctors are not spending more time. Even the doctor population ratio is more, specifically in Tamil Nadu, it is 1:250. Even though we are going to communicate, we are going to talk, they will be complaining and they will be having and they will be looking with social media, just like WhatsApp University and Google University, they keep on searching. And messages posted by those individuals, particularly with personal experience, with positive sentiment, they have a higher reach, specifically in Twitter apps. And various algorithms, artificial intelligence has been used to analyze the content of tweets, which specifically helps in understanding the need and the opinion of people regarding diabetes. There are many organizations, specifically like WHO and ADA and RSSD, they are very active in posting tweets. However, they didn't take the full advantage of communicating features in social media. Regarding the benefits or with the general people, they help to engage people in public health as well as in policies decision making. And regarding the healthcare professional, it helps to build the national and international professional networks like RSDA and ADA, and facilitates the person with diabetes to know more about the disease per se and how to control, how to manage. All this can be benefited with the usage of social media. Social media actually has the 5 unique features: data sharing, data viewing, communication, and peer grouping on online social networks. Communication is the basic tool of all social media. Data sharing of messages, documents, images, and videos, and which has that already documented, calibrated algorithms, which has the potential to share these across as a wide an audience as one desires. There are also many communication features, which includes forums and chat rooms, which work on more than selected levels. How social media is going to change the behavior? It is very helpful in changing the behavior, and this behavioral changing technique can be achieved with the usage of following methods: by demonstration of behavior, skill training, action planning, goal setting, problem solving, social comparison, social support as well as feedback. All this helpful for the changing for the person's behavior. Regarding the behavior change, these 3 factors are very important for the determinants of behavior change. The first is self-efficacy, realistic and positive outcome expectation as well as good social support. What is self-efficacy? It is actually a personal belief in their own ability to complete a task or achieve a goal, and can greatly affect the individual behavior. Actually, this is one of the very important key factor in achieving more positive patient outcome and expectations. People who believe that they will successful are more likely to make behavioral changes to produce their desirable effects. Self-efficacy plays an important role in physical health, psychological adjustment, and behavioral change strategies. And this is regarding when obese or overweight gets motivated repeatedly after seeing many videos or many messages through any social network like Facebook, Insta, and Twitter, he engages with social cognitive therapeutic concepts, which includes social modeling, observational learning, and verbal persuasion. After that, he will be going with behavioral change techniques, and he will be motivated again and again. He will be applying that. There will be change in behavioral change, which will be he keeps on increases his physical activity. He increases the energy output, and he start eating healthy foods, and there is a decrease in dietary intake of any carbs. Overall, the outcome will be decreased body weight, decreased BMI, decreased weight circumference, body fat, calorie intake, and increased physical activity. These are the benefits outcome when an obese or overweight person is going to follow and get motivated with seeing many videos in YouTube, Facebook, WhatsApp, whatever. Actually, there was a study with how healthier are you. It was conducted by the NHS Diabetes Prevention Program and proved that by utilizing the digital technology and social media, we can positively impact a large number of patients. And the outcome from this program showed that there is a mean weight loss of more than 2.3 kg has been able to achieve by using digital technology and social media. Not only that, apart from weight loss, we are able to reduce the A1C of approximately 1.3 millimole by mole. And these are the basic clinical characteristics between two patients, those who use social media and those who don't use social media. See, there is a significant difference in A1C of more than 7.1 with social media using group, while non-internet groups, they have the A1C of 7.6. However, DKA incidence, hypoglycemia, the total incident recurrence has been very much lower with social media group. However, it is not significant. These are the various discussions that takes place in the Facebook or Viber that has been used similar to the WhatsApp in the US. For example, in Facebook, one patient posted that he has achieved the A1C of 6.5. And one person replied for that comment and he has told that it is very good, but however, I am not able to maintain that. The first person reposted again. Actually, I was also the same thing. After following the insulin technique or insulin pump after starting, I started to have good glycemic control with lesser incidence of hypo as well as hyperglycemia. Regarding the same can be used with Viber technology. One person has how to implant the CGMS. He said whether it can be implanted under the arm. That one guy replied whether it can be applied, but one more guy the replied it is better to have applied through the abdomen so that we can have a tape so that it can have the duration of more than 14 days we can use without falling. And these are the difference between those people using Facebook and Viber in internet group. Most of the people, those use both Facebook and Viber, those are on insulin pump. They have a significant A1C reduction of 6.7 when compared to Facebook only. At the same time, they have a large number of posts per day, which is very more with Facebook as well as Viber. And this is one more study, the meta-analysis finding which showed that Low et al.'s analysis into social media intervention for overweight and diabetes on obese adults showed a mean reduction of weight reduction of 1.5 kg across 21 randomized controlled trials with a decrease in 0.75 BMI across all the 13 randomized controlled trials. These are social network related to type 2 diabetes mellitus. In a narrative review, in the general public will be taught through the social media about the risk of diabetes, how to prevent the diabetes, how to prevent obesity, how to prevent overweight. Not for the patient with diabetes, it helps to know about the complication of diabetes much better. At the same time, for the healthcare professional, we can apply through how there are recent technology and recent drugs that are available in the markets. Actually, how can technology help? Actually, it is an emerging trend. All the healthcare professional has to accept this evolving emerging trend, and they have to seek any help for the betterment of the patient outcomes. When healthcare professionals specifically use social media and online communities by posting many videos and many messages, they are able to reduce the A1C specifically in the type 2 diabetes mellitus. And when they are going to use some artificial intelligence based algorithms, they can able to produce the accurate personal nutrition by predicting the glycemic response for each and every food. Not only that, accurate diagnosis of diabetic retinopathy and other eye diseases, and prediction of optimal line of treatment based on data from the electronic health records. In specifically, the healthcare professional can be more beneficial for patients those on an insulin pump. By using insulin pump, they can have a good glycemic control and decrease incidence of spikes and dips with hypo and hypo, and more time spent in time in range. We can achieve more than 70% with the usage of many applications. Specifically, they are called as looping community, and decreased risk of diabetes-related complication and mortality and identification of new clinically relevant metrics can be benefited with the usage of insulin pumps. And this is by using mobile apps specifically for the doctors, centers or clinic, we can able to reduce the A1C reduction and potential benefit for the health-related quality of life, diabetes, patient knowledge and empowerment. Epidemiological study of environmental and psychological risk factors can be improved by using specific acts for the doctors. Not only that, the launch of large-scale clinical or population-based e-cohorts can be generated with the usage of all these applications that are present on social media. Social media, whether it is a friend or foe. When I am going to ask the question by showing the knife, whether it is good or bad, you will be surprised. You will be telling what is the type of question this is. Actually, by showing this knife, I am going to ask how we are going to see and how we are going to use. If a criminal uses this knife, it will be a disaster. However, when it is used by a surgeon, it will be a good outcome. Similarly, the social media, various applications, various apps are just tools. How we are going to use it matters. Social media in itself, however, it is contributing to adolescent obesity and diabetes, with a causal relationship demonstrated between the screen time and the healthy outcome. As I already said, when you're going to use a screen time of more than 2 hours per day, then you are already addicted to the social media, and you are more prone to develop overweight and obesity, mental problems, eye problems will be developed because of high usage of social media. So there is a line, how to use, when to use, how much to use. And these social media chat rooms and diabetes forums are actually helpful in improved patient understanding of their diseases better, and particularly carbohydrate counting of each and every foods. Patients are now easily able to access and discuss people with across the world regarding the insulin carbohydrate ratios, insulin sensitive factors, what they would administer for certain food via instant messaging, blogs and forums. Apps such as MySugar, DigiBite, MyDesmond and GDM Health now allow us to provide patients with resources they can use in their own time to educate themselves and better manage their diabetes. However, there are many pitfalls of social media. It incurs the increased risk of disseminating misinformation, lack of reliability, quality concerns, lack of confidentiality and privacy, risk of disclosing personal information online, harmful or incorrect advices, and there is a risk of unreliable post advice or certain health condition which lead to unwanted health problems. And social media can be viewed as a manipulative and other perceived as a business tool to sell goods and services. However, there is a conceptual gap always exists. Many senior patients will be coming and they will be only satisfied when you are going to have a discussion with in face-to-face. However, when you are going to discuss, when you are going to give consultation through virtual, they won't be accepted. There is a conceptual gap. And in end note, social media is an underutilized tool in our management of obesity and diabetes. The benefits of social media are engaging people in public health and policy discussion and establishing professional networks and facilitating patients to access the information. Social media can help in improving the health outcomes via the behavioral changes techniques such as goal setting, action planning, social comparison, social support and feedback. The regulation of information spread via social media is very vital to maintain its accuracy and use of good quality evidence. Doctors, we don't share many messages and videos and any confirmatory messages, so that many fake messages are revolving around. We have to stop that one. Once again, I thank all the my scientific committee for giving this opportunity and chairperson. I'm going to end with requesting the chairperson to allow me to play this video. I want to show about the awareness about the diabetes we used to see daily in our life.
தேவையில்லாத வேலை பார்த்துட்டு இருக்கீங்க. உங்களுக்கு சுகர் இருக்கு, கண்ட்ரோல் ஆகாது பாத்துக்கங்க.
ஏன் கண்ட்ரோல் இருக்கு தெரியுமா? முதல்ல டாக்டர் வந்து கை கொடுத்து சூப்பர் வெரி குட் சொல்லிட்டாரு.
அப்படி சொன்னாரா?
ஆமா 3 மாசமா சக்கரை கூட கண்ணல பார்க்காம இருந்ததுக்கு நீ கொடுத்திருக்க, கொஞ்சம் கொடுத்துட்டு போறேன்னா போ பார்க்காத செஞ்சு
தேவையில்லாத வேலை பார்த்துட்டு இருக்கீங்க.
குறஞ்சது சுகர் சக்கு சிக்கு சக்கு சிக்கு இனிமேல் ஃபயர் சக்கு சிக்கு சக்கு குறஞ்சு.
Thank you.
Thank you, sir, for your wonderful presentation. Actually, social media has got pros and cons. We shall take the positive point and we'll ignore the negative points. Next topic is clinical topic, ICU topic, basically, IV fluid management in diabetes. So, we call upon Dr. Neo Church Tharsis, consultant physician, come diabetologist from Crompet. Over you to, sir.
Organizing committee for giving this wonderful opportunity, and I would like to thank each one of you for dedicating your precious time. So what are the advantages of IV fluid therapy as compared to oral therapy? Of course, it is accurate and controlled by you, and there is always predictable way of administration. And another very, very important is when you give something like IV, you can have immediate response, and because of direct infusion. And what are the indications? There are many indications. Of course, all you are aware that severe vomiting and diarrhea, and it may be very useful to give IV medication, especially when somebody suffers hypoglycemia. Then if you want to give 25% dextrose, it would be very useful, and it's vehicle for various IV medication and so on. So when you have so many merits, and definitely you have to expect some kind of disadvantages. Sometimes it may produce thrombophlebitis, then it may lead to sepsis. And another very important is the improper selection of fluid also may endanger the patient. For example, if somebody is having hypokalemia, then you have to avoid 5% dextrose. When you have hyponatremia, then you have to avoid hypotonic solution. So the selection of fluid always merits. And another important is improper volume of fluid. That's also very, very important, because the extremes of age group, like neonate and elder individual, they are always prone for getting pulmonary edema. So the meticulous volume should be maintained. This is the most important slide. Then I would request you to focus on this slide. Please remember that the center part is intravascular compartment, otherwise called blood vessel. Okay. Then another one is, this is cells. Adjacent to the blood vessel, the blue color is cells. In between the cells, there is space called interstitium. Okay. So you have three compartments in our body. One is intravascular compartment, or otherwise called blood vessel. Adjacent to the blood vessel, you have cells of each and every parenchyma. Then in between the cells, you have something called interstitium. So how our body water is distributed? So basically, the weight, how much body water we have? 50% of our body weight is nothing but it's contributed by body water. For example, somebody is weighing 100 kg, then you can boldly say, the 50 kg is contributed by our body water. How this body water is distributed in our body? Please remember that 2/3 of our total body is well packed within the cells. That is called intracellular compartment. Then remaining 1/3 of body is distributed inside the blood vessel, or otherwise called intravascular compartment, then adjacent interstitium, otherwise called in between the cells. So this is called extracellular compartment. So one is intracellular compartment, which has almost 2/3 of our total body water, and the remaining 1/3 of total body water is distributed inside the intravascular compartment and the interstitium. So for example, somebody is having 100 kg of water, then 2/3, almost 66 kg will be within the cells throughout our body. Then remaining almost 30 kg will be distributed in the almost 10 kg inside the vascular compartment, the remaining 20 kg in the interstitium. Then what do you mean by osmolality? So osmolality is nothing but we have studied in the physiology. Then I will try to narrate it. Osmolality is nothing but it is a measurement of solute concentration. We have so many solutes in our body, in the plasma, sodium and potassium and chloride and phosphate and glucose and so on. But the most important is, even though we measure the solute in a very detailed way, please remember that the plasma osmolality is 290 milliosmolality. Among this 290 milliosmolality, the sodium contributes 280 milliosmolality. Otherwise, the 90% of our plasma concentration is nothing but sodium concentration. So otherwise, I could say the sodium concentration is almost synonymous with plasma osmolality. If somebody says that the patient's plasma osmolality comes down, then you can easily assume that there is low sodium or otherwise hyponatremia. Or somebody has hyponatremia, you can boldly say the plasma osmolality is very less. So how the plasma osmolality is relevant to our day-to-day clinical practice? So this is very important. See, this is, as I told you, intravascular compartment. Inside the intravascular compartment, the plasma is present. Suppose somebody has hyponatremia 120. So what happened? Your plasma osmolality will come down. Okay. What is the consequence of plasma osmolality? When plasma osmolality is low means what happened? There is one important process occurs that is called osmosis. What do you mean by osmosis? The water content of the plasma will move from the intravascular compartment to intracellular compartment. So what happened? The cellular edema occurs. That's why the most important consequence of hyponatremia is cellular edema. Cellular edema occurs throughout our body, even in hyponatremia, but the most important vulnerable organ that suffers secondary to hyponatremia is brain. Because when brain cells become swollen, where it is swollen, the brain is well packed within the solid structure, otherwise called cranium. So brain can't expand anymore, so cerebral edema occurs that leads to death. So whenever you have decreased plasma osmolality, cell will move from plasma to inside the cells, that is called cerebral edema. When you have hypernatremia means what happened? Your plasma osmolality goes high. When plasma osmolality high, what happened? So because of high plasma osmolality, the fluid will shift from the inside the cells into the intravascular compartment, then cell shrinkage occurs. In either way, hypernatremia, then ultimately brain suffers. What is the importance of IV fluids with respect to plasma osmolality? So, if you want to choose one IV fluid, that IV fluid solute concentration should exactly mimic the plasma concentration. Otherwise, you will disturb the plasma osmolality, then patient will go for either cellular edema or cell shrinkage. That's the way it is very, very important. So now we will come to each and characteristic of IV fluid. So what do you mean by 5% dextrose? Please remember that 5% dextrose is nothing but it is a plain water. It is absolutely devoid of electrolytes. There is no electrolytes. 5% dextrose doesn't contain sodium or potassium or bicarb, nothing. So for us it is nothing but it's a plain water. So what is the advantage of 5% dextrose? Dextrose can give rise to energy. That's why those who are on nil per oral, we are giving 5% dextrose to prevent starvation, ketosis. The most important the use of 5% dextrose is the correction of hypernatremia. What I told you, I want to say something about hypernatremia. Hypernatremia means, we always think that hypernatremia means the sodium is in excess. Hyponatremia means sodium is always low. For all practical purposes, hypernatremia means the sodium concentration in the plasma is normal. It is the water deficit. There is no water, so relative sodium concentration will give rise to hypernatremia. So whenever patient has hypernatremia, it always indirectly indicates that there is no water inside the plasma. You have to give water. 5% dextrose is nothing but it is a plain water. So 5% dextrose will be very useful in correction of hypernatremia. So what are the contraindication? So this is the 3 important contraindication you have to understand. When you give 5% dextrose, as I told you earlier, 5% dextrose is plain water. So how it will be, once you give 5% dextrose, once dextrose is metabolized by our body, it is a plain water. So how our body water is distributed? Something like that 5% dextrose will be distributed. Where is the 2/3 of body water? It is inside the cells. When you give 5% dextrose 1 liter, 2/3 will enter into inside the cells. Only 1/3 will be there. Among this 1/3, only that 1/4 will be there. That means what I want to say, if you give 5% dextrose, almost all the fluid will enter into cells. So the cellular edema is very, very common in 5% dextrose. That's why neurosurgeon and neurologists would love to hate this fluid because it will aggravate cerebral edema to great extent. The first most important contraindication is any post-neurosurgical procedure and any case of stroke that is likely to go for cerebral edema, avoid 5% dextrose. Another important point is, when you give 5% dextrose, only 75 ml stays back in the intravascular compartment. That means somebody has lost 1 liter of fluid. If you give 1 liter 5% dextrose, you may think that 1 liter 5% dextrose will stay back in the intravascular compartment. No, only 75 ml will stay back. So it is absolutely contraindicated in shock. When somebody has hypovolemic shock, if you give 5% dextrose, unfortunately only 75 ml will stay back. Apart from that, 5% dextrose will be metabolized to lactic acid in the absence of oxygen. So what happened? There are so many complications are there. Then another important point is when you give 5% dextrose, it will evoke insulin secretion. Insulin will push the potassium from the plasma inside the cells. So it is absolutely contraindicated in hypokalemia. Then another important contraindication is hyponatremia. As I told you earlier, hyponatremia means it is not true hyponatremia, always water excess. Hypernatremia means water deficit. When you have hyponatremia 125, 126, there is water excess. So when you give 5% dextrose, again what will happen? It will worsen hyponatremia. So these are the few contraindications of 5% dextrose. What about normal saline? So actually normal saline, this is a misnomer for us because the reason is normal saline contains two electrolytes. One is sodium and chloride. The normal plasma sodium concentration is 140, but it is excess. And the normal chloride concentration is 108, plasma it is 154. So it is excess sodium and the excess electrolytes. So we can't say it is not normal, it is an abnormal saline only. So where it scores over other IV fluid. When you give normal saline plasma osmolality is almost close to plasma osmolality or more than the plasma osmolality because the sodium concentration is almost equal to plasma sodium concentration. So what happened when you give normal saline will stay back in the intravascular and interstitium compartment because unlike 5% dextrose that is plain water, so plain water only will enter into cells. Normal saline will be distributed in the interstitium and the intravascular compartment. As I told you earlier, ECF compartment 2/3 here, only 1/3. So when you give 1 liter normal saline, 750 ml enter into interstitial space, 250 ml will stay back in the intravascular compartment. The only one IV fluid that can offer maximum amount of water inside the intravascular compartment is normal saline. So that's why normal saline is the undisputed leader of choice in resuscitating the shock. So if you give 5% dextrose, only 75 ml. So then apart from that, why it is contraindicated in edema and volume overloaded state? What is edema? Edema means fluid accumulation in the interstitial space. When you give 1 liter of normal saline, 750 ml enters into the interstitium space. That means you are worsening the edema. That's why it is contraindicated in all kind of edema. Because there are so many things are there, it will demand at least 1 hour, then I will try to cut short everything. And in fact, it is the most important fluid of choice in vomiting. So I have witnessed many areas for vomiting, they are giving ringer lactate. Ringer lactate will worsen vomiting. And in fact, normal saline will be helpful in vomiting because the vomiting, there are so many electrolyte disturbance. Hyponatremic, hypokalemic, metabolic alkalosis, so many electrolyte disturbance. But everything is induced by one important simple factor is hypovolemia. Hypovolemia worsens all the electrolyte disturbance. When you offset the hypovolemia, every electrolyte disturbance in vomiting will be corrected. But wherever you have hypovolemia, wherever you have shock, again the normal saline would be the choice. That's why normal saline would be the choice of fluid in vomiting. And wherever hypovolemia, for example, when you have DKA initial phase, definitely you require, when patient comes with shock, you require normal saline. Hypercalcemia is one of the reason for polyuria. Yes, and fluid challenge in pre-renal or all the condition, normal saline will be very useful. The most important contraindication is, as I told you, edema. Then another important emerging concept. So another, the way back in the last decade, we always think that normal saline will cause only volume overloaded state. So we will always check any signs of volume overload state. Otherwise, you give normal saline. Now they have found that it produces hyperchloremic metabolic acidosis. So what do you mean by hyperchloremic metabolic acidosis? It has been stated that whoever comes with shock or whatever reason, if you give normal saline more than 2 liter, what happens? As I told you earlier, already the chloride concentration is very, very, very high as compared to the plasma concentration. This hyperchloremia, what happens? It stimulates macula densa present in the distal convoluted tubule, which in turn stimulates the constriction of afferent arterioles of the kidney. So what happens? The kidney go for vasoconstriction, it leads to acute injury. This is the emerging concept. So if you want to resuscitate shock, give normal saline quickly. If patient achieves 90 or 100, you switch over to balanced solution that yet to be taught by me. So, and how it causes metabolic acidosis? Normal saline dilutes bicarbonate, it inhibits absorption of bicarbonate, everything. So many mechanisms are there. Please remember that When you give normal saline, restrict normal saline 1 to 1.5 liter. Don't go beyond 3 liter, 4 liter. It may induce hyperchloremic metabolic acidosis. Ultimately, it will lead to acute kidney injury. Then what is DNS? DNS, the composition is exactly similar to normal saline. Only one thing is dextrose is added. So whenever patient is on NPO, then definitely DNS can be given. As I told you earlier, somebody has intractable vomiting, we used to give normal saline. The added advantage is dextrose. If you give dextrose, then patient will not go for starvation ketoacidosis. Suppose somebody can ask, NS can be given for resuscitation of the shock. Why not DNS? Yeah. If you give DNS, what happens? More and more glucose. For example, if you transfuse DNS more than 600 ml in 1 liter, more than 600 ml in 1 hour, what happens? It will cause osmotic diuresis, by which patient will lose the fluid. So the purpose of the purpose of treatment of shock will be absolutely defeated. And moreover, during the time of shock, if you give dextrose containing solution, what happens? Dextrose will be converted into, unfortunately, lactic acid. Lactic acid with further causes profound vasodilatation, again will go for shock. Any kind of dextrose combination better to avoid during the time of shock. Then what is ringer lactate? Yeah, ringer lactate, what is how you can compare to normal saline? Ringer lactate, yes, it contains almost something like normal saline sodium, but normal saline sodium is 150, more than our plasma sodium, but it is lesser than the plasma sodium, but still it has sodium, okay. One. Another, as compared to normal saline, it contains additional potassium and it contains additional calcium. So normal ringer lactate almost contains most of the plasma electrolytes. That's why ringer lactate is always considered as a most physiological IV fluid. It contains sodium, it contains potassium, it contains chloride. In addition to that, it gives rise to lactate. What is the fate of lactate in our body? If you give ringer lactate, the lactate will be converted into bicarbonate, which in turn corrects the acidosis. So wherever you suspect acidosis, for example, somebody is coming with sepsis with mild shock, 90, 94 BP. If you give ringer lactate, because it contains sodium, so it can elevate your blood pressure. It contains lactate. So what happens? The lactate will be converted into bicarbonate. So bicarbonate will correct acidosis, septic associated acidosis. And moreover, it will be used, this is the reason it will be useful for diarrhea also. So diarrhea, what will happen? So diarrhea is nothing but lower GI content loss. Lower GI content contains rich amount of potassium. So because of diarrhea, you will have lot of hypokalemia that can be corrected by this presence of potassium. That's why we won't give normal saline for diarrhea, because now diarrhea warrants potassium correction. Normal saline doesn't contain, but ringer lactate contain. Diarrhea causes, because of bicarbonate excretion, diarrhea causes profound metabolic acidosis. Ringer lactate contains lactate to correct acidosis. So the the fluid of choice for diarrhea is ringer lactate. Fluid of choice for vomiting is normal saline. But only one disadvantage of ringer lactate is the conversion of lactate into bicarbonate requires intact liver function. Intact liver. That means, suppose somebody presents with acidosis, sepsis, but liver is compromised. Suppose if you do liver function test, SDPT 400, 500, if liver is compromised, unfortunately lactate can't be converted into bicarbonate. So ringer lactate may worsen the acidosis. So the most important contraindication for ringer lactate is in the presence of liver disease. And as I told you earlier, during vomiting also, if you give ringer lactate, it will worsen the vomiting induced alkalosis. Then you have plasma-lyte. This is the most sought after fluid. Nowadays, we start using plasma-lyte very aggressively. What is the difference between plasma-lyte and ringer lactate? Yes. As compared to ringer lactate, as I told you earlier, ringer lactate contains everything. There are only two disadvantages. Its sodium is slightly lesser than the plasma. That disadvantage has been corrected. The plasma-lyte, the name itself implies plasma. Its concentration is exactly similar to the plasma. Our plasma sodium concentration is 140, then plasma-lyte concentration also 140. Our potassium concentration also 5 milliequivalent, somewhere around. This potassium also 5 ml. In addition to that, it offers magnesium. Then most important difference between ringer lactate and plasma-lyte is it gives rise to acetate. What is the acetate and lactate? Both serve same purpose. Lactate also will be converted into bicarbonate, but it warrants intact liver. But acetate can be converted into bicarbonate by any cell in our body. So even in the presence of liver dysfunction, when you find acidosis, this is the fluid of choice. And the plasmolite is very, very safe. So previously, it has been thought that whenever you have hyperkalemia, potassium is high means ringer lactate contains potassium, so avoid ringer lactate. When you have hyperkalemia, so potassium, plasmolite contains potassium, don't avoid hyperkalemia. Nowadays, the emerging concept would be most of the hyperkalemia is secondary to metabolic acidosis. So, if you correct acidosis by either ringer lactate or by means of plasmolite, what happened? The acidosis induced hyperkalemia will be diminished. So nowadays, the hyperkalemia won't be the absolute contraindication for ringer lactate or plasmolite as we thought earlier. So now, plasmolite, there are many growing literature supports many evidence that plasmolite can be utilized in resuscitation of the shock. When you find shock, normosaline would be the first choice, but when BP picks up somewhere around 90, then if you give plasmolite, it can also elevate BP. The most important, the shock associated acidosis can be converted because it doesn't warrant any intact liver function. Of course, diabetic ketoacidosis, initial part when somebody presents with shock, give normosaline. But once BP picks up, then what automatically you can switch over to plasmolite or ringer lactate. Also, in the presence of liver dysfunction, you can give plasmolite. Then we come to isolate. So isolate, if you take isolate, there are so many isolates there. Isolate M and isolate G, isolate P and so many isolate. Two important common feature of isolate is all the isolates contain enormous amount of potassium. We are talking about ringer lactate only 5 milliequivalent. We are talking about plasmolite only 5 milliequivalent. This all isolate contains 20, 40, 50 milliequivalent. Almost 2 ample of potassium is simply well packed within this isolate. So the most important contraindication for isolate is wherever hypokalemia is seen. The most important day-to-day clinical practice is acute kidney injury. So acute kidney injury and CKD, all the isolates are contraindicated because it contains enormous amount of potassium. And second one, all isolate contains dextrose. So it should be avoided in diabetes. And another important point is it contains only half sodium. For example, normosaline almost 150 sodium, ringer lactate 130, and plasmolite 140, all 130, 140, 150. But all isolate, everything only 40 and 50 sodium. So definitely, whichever IV fluid that contains less amount of sodium, that IV fluid can't be used to anything for resuscitation of shock. It is contraindicated for shock. And another important, since all sodium, it's only half the sodium it has. That means how the osmolality would be? Osmolality would be definitely less. So definitely it is contraindicated in all kind of hyponatremia. So there are so many things are there. Isolate G is very, very useful in vomiting. So vomiting, you know very well that what happens in the vomiting, all the H plus will be excreted. So patient will go for alkalosis. The only one IV fluid that can offer H plus is nothing but this isolate G. But please remember that isolate G contains ammonium. Once ammonium is infused, ammonium will be converted into ammonia plus H plus. But only one thing is, where is the threat of ammonia always will be there in the liver dysfunction. So in the liver dysfunction, you can give isolate G refers to gastric. So whenever patient has severe vomiting, definitely you can use isolate G. So as I told you earlier, isolate P, isolate G, almost everything. They are very rich in potassium, only half the sodium, and they will have correction of acidosis and everything will be there. So almost we have come to an end. So the most physiological IV fluid nowadays, one is plasmolite and ringer lactate. But the difference between plasmolite and ringer lactate is, as compared to ringer lactate, plasmolite sodium is almost 140, entirely mimics like our plasma. And another one is plasmolite and ringer lactate both are capable of correcting acidosis, but plasmolite is capable of correcting acidosis in the presence of liver dysfunction. The best fluid for hypovolemic shock, there is no doubt about that. Normosaline still the leader in resuscitation of the shock. Only one thing is, if you give more than 2 liter, the patient may go for hyperchloremic metabolic acidosis and it may induce acute kidney injury. Once BP has picked up around 90 or 100, switch over to balanced solution or otherwise called plasmolite and ringer lactate, which has added advantage, something like the acidosis can be corrected. The acidosis can't be corrected by any other, by normosaline. That's very, very important. The fluids to be avoided in renal failure, as I told you earlier, the most important two consequence of any kidney injury or kidney failure is, one is hyperkalemia and metabolic acidosis. These are the two dreadful consequences of kidney injury. So whenever patient has hyperkalemia secondary to kidney injury, you have to avoid potassium containing IV fluid, especially all isolate, because isolate contains 20, 30, 40, 60. And second one, fluids that correct acidosis, as I told you earlier, ringer lactate and plasmolate, and all the isolate contains good amount of buffers that can correct acidosis. So what are the fluids which are glucose free? Normal saline, no dextrose, ringer lactate, no dextrose, plasmolate. These fluids can be liberally given in diabetes based upon the indication. The sodium free, only 5% dextrose. That's why whenever patient has hypernatremia, we give sodium free solution, nothing but plain water we used to say, that is 5% dextrose. So potassium free, isotonic saline and DNS and dextrose. So rich in chloride and everything, DNS, normal saline and so on. So I will come to the proper topic. So what are the IV fluids in diabetic? Suppose any diabetic patients comes with diarrhea or vomiting or any other thing, it won't be different from any normal individual. When somebody has DKA, of course say that when somebody is labeled to have DKA means that patient has lost almost 6 to 9 kg of water. So initial fluid resuscitation should be always normal saline. Once BP picks up, balanced fluid can be given, something like ringer lactate or plasmolite. Then once sugar comes somewhere around 250 milligram, then we will always switch over to 5% dextrose. Am I right? So 5% dextrose we give for two reasons in later part of the DKA. One, usually in the DKA, there will be early resolution of the hyperglycemia. Hyperglycemia will disappear very quickly within 8 hours, but ketosis will persist for more than 24 hours. To prevent ketosis, we have to give insulin infusion even though your glucose becomes 250. Okay. So during the time of insulin infusion, to prevent hypoglycemia, once glucose reaches 250 milligram, we switch over to dextrose solution. Another important dextrose solution, the important feature of dextrose solution is, in DKA, it is not only the intravascular depletion, there is intracellular dehydration also occurs. Intracellular dehydration occurs, intravascular depletion occurs. The initial intravascular depletion is corrected by what? 0.9% normal saline. But intracellular dehydration will be only addressed by 5% dextrose. As I told you earlier, if you give 1 liter of 5% dextrose, how much intracellular compartment receive? 2/3 of 5% dextrose enters into the intracellular compartment, 660 ml. So intracellular dehydration will be much evident in DKA. So once you resuscitate the intravascular compartment, the later part of intracellular dehydration is addressed with 5% dextrose, because this is the only one IV fluid goes into the intracellular compartment. That is the reason we avoid 5% dextrose for cerebral edema and so on. I think that with that I would like to end, because so this is a 1 hour topic. I have curtailed so many slides, and I don't know how much you are able to absorb your brain, whether you are in the cell shrinkage of cerebrum or in the cerebral edema, I am not sure. Thank you.
So thank you, sir, for your wonderful presentation. It's a more technical presentation, ICU topic. So you mentioned about plasmolite pH 7.4.
Yes, sir.
What about NS, sir, normal saline?
For what?
pH, sir, pH.
No, I am not aware of it, sir.
Actually, it is written as 6, sir, actually.
Okay.
6 is acidic pH, actually. We are using it for DKA as a primary fluid of choice in acidosis also.
Okay.
It looks like a controversy in since as a pH is concerned.
Okay.
7.4 is plasmolite, which is plasma pH.
See, acidosis basically, the acidosis mostly it is due to intravascular depletion, and because of shock, they will go for lactic acid and everything. Then another important is because of acid derived from the ketone bodies. So I think that one end we are addressing insulin infusion, one end we are resuscitating the shock. I think that the pH may not be matter. I think that with respect to these two pathophysiology.
We are using as a primary fluid is normal saline initial phase actually.
Okay.
But pH is 6, sir, actually.
Okay. Anyway,
compared to isolate pH 7.4, which is near plasma pH.
Okay.
But this one is 6, sir.
Okay.
We are using it for acidosis actually. Initial phase correction. Okay.
But
anyway, your topic was very excellent topic. You went to each and every fluid in detail. Very excellent topic, sir. Thank you very much for your presentation. Thank you, sir. Now to the forum. Any doubt can be clarified? Any doubts?
Complicated topic we generally fail to catch up. You have given it in the very basics, beautifully done. Thank you so much. One question to Dr. Vetrivel, sir. Sir, you said all vegetarian food and fruit and vegetables with skin that gives the maximum of gut microbiome. Okay, but what about the pesticides on them, sir? That will also destroy the organisms.
Not the organism which is destroyed by the pesticides are they are okay,
Harmful,
but the vegetables skin, the vegetable fiber is not digestible by our enzymes, proteolytic enzyme, whatever may be, but they are capable of digesting by the gut microbiota. We call it as saccharolytic fermentation, out of which they produce short-chain fatty acids, propionic, acetic, and butyric acid. Each and everything has got own function. For example, butyric acid is the one which is useful for energy conservation and energy harvestation. Propionic acid and the acetic acid are useful in acting on the G receptor, G protein, Takeda receptor, coupled receptors 41 and 42, which are useful in kindling the endocrine L cells and producing more GLP, and also they produce pancreatic polypeptide and polypeptide YY. This polypeptide YY and GLP-1, also GIP, you all know, it is preventing the beta cell apoptosis, and it promotes the the growth of beta cell, and it improves the insulin secretion. And also they produce GIP and GLP, they produce satiety by the gut neural axis, where a lot of things are there. So they not only produce satiety, but also they delay the gastric emptying. By that way, your postprandial glucose is mitigated.
Yes, yes, sir. I actually asked for pesticides, which are also this thing. How can we eat the fruit or vegetable with the skin?
That's why, one of the factors that is inhibiting the gut microbiota is the sanitation. Yes. Even if you wash our fingers, our skin, and everywhere, oral orifices, everything has got richness of this microbiota, which are washed away because of improved sanitation. Improved sanitation is one of the culprit, usage of toilet soap and etc. And that's also the improved
very well
organic. That is why we promote organic farming.
Thank you, sir.
So now I will request the chairpersons to kindly give up the mementos.
Regarding the microbiota as well as the probiotic prebiotics, any drug which is given, any antibiotic, you should supplement with the prebiotic and probiotic. That is very important, sir, because the people think this only for diabetes, but it's very important because we should not wash away all the good bacteria from the gut.
So I request
there is one antibiotic by name ciprofloxacin. They wash away 95% of the gut microbiota. To restore the diversity and robustness of such microbiota, it takes 7 weeks.
1 year.
Sir, excuse me, sir. Sir, we have oration in the MV hall next, so you can have your one-to-one discussion afterwards. So we will go ahead with the... I request Dr. Damodaran to present the memento to Dr. Vetrivel. I request Dr. Shiv Kumar to present the memento to Dr. Palani Kumaran. And I will request Dr. Palani Kumaran to present the memento to Dr. Damodaran, sir. I request Dr. Shiv Kumar to present the memento to Dr. Ranjit Pratap.